Hello, and welcome back to another episode of AdvoKAYte, Holding Healthcare Accountable. I'm thrilled to have Dr. Henderson and Dr. Lazar with me for another episode where we just really talk about how medicine has changed over the time that they've been practicing. So thanks for joining, and I hope you'll really enjoy this conversation.
So that's a mandatory requirement in the neurosurgical training programs of this country. That does not exist in other specialties. For example, Duntsch would never have qualified to be certified in neurological surgery. He could not even take his board exams. He was not registered to take exams from the time he started. In neurosurgery, that's no longer the case. Every resident is registered with the American board. So a guy like Duntsch gets out and calls himself a neurosurgeon, but he's not qualified to take board exams. That should be a minimum requirement to practice in a hospital. And unfortunately, we have not been able to influence the ACGME to implement that same system that the American Board of Neurological Surgery has implemented.
Well, I think you're being overly modest when you said we got that done. That was primarily you, if not solely you, who got those very important changes made at the ABNS level.
It was not me alone. Dr. Henderson, along with another colleague, we together wrote and cajoled. We tried to impress change. And the other issue that helped make that change was all the public information that was generated by the group in podcasts and in the programs that were on television. Yeah. These were very embarrassing to the American Board of Neurological Surgeons and to neurosurgery in general. It made neurosurgery look pretty bad. They've done a good job in rectifying their shortcomings. But the same thing has to be done with all the other surgical specialties.
Would this, in your opinion, prevent another doctor death, a conflict of interest situation, a financial conflict of interest where, or other reason, where a clearly unqualified, if not dangerous, surgeon is passed out of residency?
It's one major step, but it is far from being the cure to the problem.
Well, I just wanted to say, as a side note, that I'm sorry I overlooked acknowledging Dr. Henderson's efforts there. The two of you are both modest, and this is not a quality that is known to exist among spine surgeons and neurosurgeons.
Modesty?
Yes.
We could lose our board certification.
Well, let's talk about, this is a good segue to something else. When you talk about it's not the panacea, The other problem that we have is whatever you want to call it. I mean, I can remember when I first started studying medical malpractice law, we had a little thing, lawyers will recognize this. We had little books called the nutshells, and it would sum up things in a nutshell. And it was kind of a cheater's way to kind of get an overview of the course before you dove into the textbook. And back then, back in the horse and buggy days, we were talking about the code of silence in medical malpractice, the physician's code of silence, and how they won't talk bad about another surgeon and how that's bad for patient safety. And I won't count how many years ago that's been, but I think it's been at least 40 years, and I know it existed long before that. So, we know that there were a very few surgeons who came forward to speak publicly against Dr. Duntsch, to make complaints to the medical board, to pressure hospital administrators to strip his privileges, and so forth. But for every one, there were 100 who didn't speak up. So, and we also know of situations beforehand, but since when we have our little meetings, our No More Dr. Death meetings, we talk about other cases, other just atrocities, where other surgeons haven't spoken up or other doctors haven't spoken up. So my question that I want to throw out there is the code of silence alive and well, and is that good or bad for patients?
It's interesting. It's we're not taught a code of silence. I think we used to be taught if not a fear of the legal profession, maybe a dislike of the legal profession, not because of experience, but because of maybe the experiences of our mentors around us. And it was always it seemed to be a negative thing. And then you might get exposed to somebody on the staff that was working with the legal profession in personal injury cases or maybe even expert witness situations. And right or wrong, there was negativity connected to it in the open discussions by other physicians in the doctor's lounge, et cetera, et cetera. So nothing obviously ever formalized, but it was always just the influences that collectively that made the difference. And only when you get exposed more directly, I think, to the legal profession as it relates to medicine, do you become more pragmatic about the relationship and understand that there's good being done on both sides to correct bad. So, and I really don't have a feeling for how it's affecting the physicians that have been coming up over the last 10, 20 years. It seems like it would be dissipating because physicians don't have the time anymore, or if they ever did have the time away from their practices, to actually commune much with their peers. We just don't get the opportunity to do it. Like county medical societies, when they were first established, 100 years ago or so, for decades, virtually all the physicians in the community would go to those meetings on a monthly or quarterly basis. And that's where they got to catch up and with old friends and old peers and meet new ones and establish referral basis and connections. And now for the last 20, 30 years, that's been obviated. Most physicians don't have referral practices anymore because it's all dictated by the insurance carrier. What book you're listed in and what book you're not. You know, your family practitioner just says, I don't know who to send you to. Don't you have a book? Well, I used to have a book. Well, if you don't have a book, look it up online and pick one. And then I'll tell you if I know them or not. That's kind of how it goes. And so I don't know if that answers your question or not, but that's my reflection on it.
It does, and I want to give Dr. Lazar an opportunity to weigh in if he wants.
No, I think Bob summarized that very well.
Well, I think it's a great segue into talking about some of the ways that medicine has changed over the years that you all have been practicing. And referral relationships are one of those things. It used to be that physicians referred to physicians who they knew and they had referral relationships with, so they could also have not only a personal opinion, but some data, because I refer all my shoulder surgeries to Dr. So-and-so, and then I follow those patients and I know how they're doing. But it's not, to your point, it's not just insurance companies, but if you're all a part of the same, sometimes there are these giant groups and they're expected to refer to each other. Or if you're a part of a certain hospital system. One of the things we know about Duntsch is that other people that were in the hospital system were encouraged to refer to them. And a lot of good doctors referred patients to him because he was in the same hospital system, exactly. But they didn't know him. So have you experienced that, Dr. Lazar?
Absolutely. Duntsch is just one great example of it, where internists who I know are excellent physicians referred cases to Duntsch because the system required it.
Yeah.
And that system still exists, and those concepts apply more commonly, virtually on a daily basis, as the systems, the mostly hospital-based practice systems, grow larger. So they're recruiting physicians constantly, building their base of referring physicians, and that's referring patients into a captive, or engaging them in a captive system.
Let me give you a little data. In 2023, 77.6% of U.S. physicians were employed by hospitals or corporations. So that was not the case when you all began practicing.
No.
Right? I guess.
Didn't exist.
Yeah.
Did not exist.
Why do you think there's been a shift from private practice, either a solo practice or a small group of doctors banding together in a practice, to going to work for either large groups, some of which are owned by private equity firms, or giant hospital systems?
Well, there are a couple of reasons, but the cost for a physician in private practice to maintain private practice is almost prohibitive.
Yep.
Even for groups, the cost of maintaining practice is very high. And the rates at which they're being reimbursed is getting tighter and tighter each year, with a lower level of reimbursement for the level of activity that's expended. And so with remuneration being diminished and the individual or small group of physicians not being able to effectively compete against larger groups for better rate of reimbursement with insurance companies, you see far less individuals, physicians going into private practice. Right. They're not going to be able to compete, and financially, it's almost a death knell. The other thing, of course, is that the physicians coming out of training these days have a different concept of practice, and they want more free time. They want a better quality of life. And so there's less of an impetus to go into business on their own in a private practice or even in a small group practice. So there are several factors involved.
It's interesting. Some doctor told me at one time, that when he started his practice, his wife ran his practice. And he said, now I'd need an MBA in healthcare to run my practice. It's become so complex. Another little statistic, and I don't have it at my fingertip, but, we have the costliest healthcare in the world, but we don't have the best healthcare in the world. We fail on multiple metrics, but the largest single segment of healthcare costs is administrative costs. And I think that's so ironic because, healthcare is a highly regulated industry, and that's good, but they're not regulating the right things. They need to be regulating hospitals' peer review and credentialing of doctors, but we've got our priorities wrong in a certain sense. But what good could come of doctors being employed by large hospital groups or groups owned by hedge funds or private equity versus what are the threats to physician autonomy, independent medical decision-making, patient safety, things like that?
Right. Well, the best aspect of it is it allows a physician to do what he's trained to do. It's practice medicine to the best of his ability. Without, and I say practice medicine, I mean actually with the patient. And that's very desirable, particularly if you're earning a good living and can provide for your family and your future needs and so on and so forth. And that's the attractiveness of it, particularly for young physicians coming in and many, many times for the physician that's in the autumn of his practice years. He says, well, geez, I'm just getting buried by these rules and regulations and having to hire and replace employees, every few months, every few years, because they get paid more at the next place than I can pay them now, or other circumstances, or just having to expand his overhead because of the increasing rules and regulations and just trying to collect on the services that he has provided. You have to have a staff of people doing your billing and collecting, which is ridiculous. It literally ought to be that since everything's codified now and has its own code number, this is what I did. You put it in your computer, which has to be done anyway, and you push send, and it ought to go to the insurance company and ought to come back a few seconds later paid.
Right.
And then if they find that there are outliers in their system over a period of weeks or months or years, and you're saying, well, look at this guy's earning 10 times more than every other spine surgeon we see. We didn't need to look into that. Well, it turns out he's got the best practice there ever is, and so on and so forth, and there's actually nothing wrong, and he deserves, or his practice or group deserves that. Or there's a problem, and they go after him. But that's not how it is. The industry presumes everybody's cheating, and then they take every effort they can to slow down their remuneration process. You don't get paid for a good practice, a good efficient practice now gets paid in 45 days. But if you don't have people and a big enough staff to stay on it, you're waiting 60, 90, 120 days, sometimes over a year to get reimbursed for some of these things, because you have to keep resubmitting the same things over and over and over again. So it's that kind of frustration in the practice. And as Dr. Lazar said, remuneration for individual services over the last several decades is going down and down and down, where your practice costs, your overhead costs keeps going up and up and up. Because you have to pay your employees more, the insurance costs more, rent costs more, your supplies cost more, everything costs more, except the physician remuneration keeps going down.
Right. Yeah, I just don't get that. I understand why health insurance companies want to squeeze out more profits so they can, their executives can make, $50 million a year or whatever it is. I can understand why the government wants to save money, but even great doctors who have the best training, the best skills, the best of intentions, they're being squeezed so hard to see so many patients and not have the time to spend with the patients that they need and deserve. It's just a setup for disaster.
It is.
But, well, Dr. Lazar, I want to pitch this question to you, which is, when we're talking about hospital employing physicians, owning physician practices, it's akin to something we've talked about before, which is the prohibition on the corporate practice of medicine. So the longstanding law has been hospitals cannot practice medicine. Hospitals are not able to tell a physician what diagnosis to make, where to make the incision, what medicine to prescribe, et cetera, et cetera, et cetera. But that line is very blurry, and modern-day hospitals do exercise considerable influence over the practice of medicine. Can you discuss that?
Unfortunately, you're absolutely right. In Texas, I don't know about other states, but in Texas, hospitals are prohibited from practicing medicine. But the hospitals have worked a system where effectively they do exercise considerable control, and they're not allowed to directly employ physicians, but they have created, each hospital creates an entity that employs physicians. The physicians are supposed to be in control of how that entity is run, but in fact, in common practice, the hospital representative that's managing that entity is really the one in the end who exercises considerable control. It's very frustrating for the physicians who are practicing in it, and they don't have much ability to change.
Right.
And and one of the problems is that once they get into that situation, they can't get out.
You mean the physician?
The physician, yeah, they
Right.
can't get out without suffering significant consequences, like a lack of any patients and a lack of any income stream coming in, because they're on a salary basis, and once they leave, the salary stops. They don't have an account receivable to go after anymore.
And they may be under a restrictive covenant where they can't practice within a certain geographical location.
Yeah.
And that is enforceable, at least in Texas.
Yep.
Well, you know, hospitals are one thing. Hospitals owned by private equity, which I call hedge fund, whole nother thing. Or practice groups owned by private equity or whatnot. And, you know, when you get a group of hedge fund people coming in and owning medical practices or hospitals or whatever, they always say, oh, we don't practice medicine. We don't tell the doctors how to practice medicine. But what we do know is that they are financial people who are looking for a very high return on their investment. And I am no hedge fund expert, but I know enough to know that when a hedge fund comes in and buys any business, it's usually to make the business more profitable, turn a profit, and then turn around and spin it off, sell it. And there's two ways that I know of to make money. It's to do more work and cut the cost. So, you know, what I see from where I sit is more and more private equity ownership. Medical practices, hospitals are very attractive investments for them. And I wonder what you all's thoughts are on whether that's good for physicians who practice in those environments, and ultimately whether that's good or bad for patient safety.
I think in the long run, it's not going to be to the benefit of patient safety or for the good of physicians. The only people who are going to benefit are the stakeholders in those hedge funds. And then people will be left with the hospitals trying to pick up the broken pieces. And that will be a very difficult task because the system of healthcare in hospitals will be broken. For me, it's very disconcerting. That kind of money and the drive for return on investment, that, in my view, needs to be taken out. It may be naive to some people to hear that, but that kind of money is not good for the system. It's not improving the quality of care. It's not improving the facilities available for patients. And so somehow rules need to be changed to take that concept out of the equation.
You know, what it's allowed is for our healthcare system to be ranked from probably one of the top 3 in the world 34 years ago. to whatever it is now, 21st or 26th or 27th or something. And it depends on what parameters you're measuring, but under most of the parameters, we don't rank so well,
Right.
except number one for cost.
Yep.
And number one by a large margin for cost. So, I mean, those numbers just speak for themselves. When the hospital industry started in the 1800s, it was started by physicians and run by physicians. And then it got a little more complicated, and physicians were having to retire from their practices to help manage the hospitals, et cetera, et cetera. And so other individuals business-oriented people came in to manage the hospitals. Well, it was interesting. When I moved to Dallas and interviewed at the hospitals for staff privileges, I would meet with the administrator. I wouldn't meet with a credentialing person or a recruiter. I would meet with, that was the way it was. You met with the administrator, the guy who ran the hospital. And then he'd tell you his story. He or she would tell you his story of, I wanted to go to medical school, but, things didn't work out, whether it was these test scores or something, or I just couldn't afford it, or I didn't want to spend the time, et cetera, et cetera. But now I get to be in healthcare, and this is great. I get to get the best of both worlds. And that's how our hospitals ran. And you had nursing staff and hospital staff that would be there for 10, 20, 30 years.
That's right.
And then we evolved as it got to be a bigger industry, and now represents, I think healthcare represents 26% or so of our GDP.
Yes.
I mean, it's a significant number. And now we have professional business people who sometimes don't know how to open up a Band-Aid or apply a Band-Aid, running these hospitals. And they're only concerned with the numbers. And that's how they treat it. So we have hundreds of thousands of registered nurses in this country that aren't working. Pure and simple because of the fact they don't want to be on a rotating schedule throughout the week, as their families grew, et cetera, or they're now empty nesters with their husbands or significant others in their family units. They want more control over their time. Mm-hmm. But the bean counters say that's not the way to do that. We've got to rotate our staff. Sometimes you're working 7 to 3, sometimes you're working 3 to 11, sometimes 11 to 7. And don't forget, you'll be working 12-hour weekends once a month, et cetera, et cetera. Yeah. Well, that makes no sense. But every big system I know is doing it that way. And so you have hundreds of thousands of nurses, of which we need a lot of them back in the workforce. And a lot of times they were the best nurses. They're unavailable. They're not going to come back into that environment. And the bean counters can't understand why.
And I would add to that, what I hear from nurses all the time is, we need you to work a double shift, and we're short-staffed. So I need you to do the work of 2 nurses or 3 nurses.
Exactly.
And,
exactly.
Yeah. Well, let me throw another one here at you, a term that did not exist when you all first began practicing, physicianpreneur. Have you heard that one?
I heard it from you the other day.
The physicianpreneur. And so, I would say my commentary on that is, I know some physicianpreneurs that I think are great doctors, and they have decided that it's better to bring some office-based procedures in and do them in their facility, or have their own physician-owned surgery center or whatever, and they have taken patient safety very seriously, and they get their surgery centers accredited, and they make sure that they have, ACLS certification for their people so they could resuscitate, and they have the equipment if there were to be an emergency or whatever. In some cases, patients get better care there. The problem is there's no way for the patient to discern a good physician who happens to be entrepreneurial, and that's fine. Physicians should make money, versus a con artist, a scammer, a crook. So I'll just throw that one out on the table. What do you think of the modern day physicianpreneur, good or bad for medicine and good or bad for patients?
One of each.
Yep.
There are certainly examples of superb facilities created under an entrepreneurial experience. But also there are some horrid examples of facilities run by physicians that those patients are compromised daily. Yeah. The problem is regulation, and it's not being done well.
Yeah.
Yeah, I'd agree with that entirely. Problem's regulation, and it's not that it's either being done or not being done. It's really how to do it, and who does it, and who pays for it, and but it needs to be done, but when you look at the issue, in my mind, the best way to administer medical care is through physicians. And if physicians have more control to administer that care, whether it's diagnostic or therapeutic, the better the system will be. Again, what's the best thing for the patient? But the practical reality of it is that it can be abused under those situations. It can be abused under any situation when you come right down to it. But the argument is, well, it's easier to abuse it with the physicians in control than it is with other people in control, which becomes the argument. But then the business people are the ones that have all the money, so they end up winning the arguments. So it's an issue. It's an issue.
Well, as you were saying that, I was thinking to myself, a happy physician is a safe physician. Not always, but I want my doctor to be well-rested, not to have pressures to see too many patients. I want my doctor to be well-compensated and not having to see more patients than is safe in order to feed her family or whatnot. But well, let's finish up here. I want to do a lightning round, and I got 4 questions for you, and we'll just go back and forth. One thing you'd bring back from the good old days.
Say again?
So, from the good old days of medicine, if there's one thing you could bring back that was good about medicine 30, 40 years ago, what would that be?
I know what it would be.
Okay.
I know what it would be. One of the best things that I ever saw in my training was we used to have physicians come watch us do our procedures from all over the country. Well, all over the city, all over the state, all over the region, all over the country, and from other countries. And all they had to do was call us and ask us if we could come, and we would say, and some of them would literally just say, well, I'm here for a meeting, for 3 days. Can I stay over on Monday and Tuesday and come watch you guys in the OR and in your practice maybe? And we said, sure. And there was never any problem. Maybe that morning we'd tell the OR supervisor, oh yeah, there's going to be 2 guys showing up here that are going to want to scrub in and watch the case. Well, they would, and we had that sharing, that cross-pollination of experiences and techniques and so on and so forth, both in the operating room and in the doctor's lounge, and usually going out to dinner afterwards, and that's what it took. But over the last I don't know what it is, 15 years or so, 10, 15 years. Now you have to make that reservation several months in advance with the hospital so that they can do the minimum 6 weeks of credentialing to get their temporary privileges approved so they can come into the operating room and stand behind you and watch and not get up to the table. So there's pros and cons to that, but there are a lot of pros because teaching never stops in medicine.
That's right.
It's a good point.
What is one modern advancement you love? Or you could say another. What's the greatest advancement over the course of your career?
Technology improvement. There's been enormous change in technology, at least in my specialty. And that's both from a diagnostic standpoint and from a therapeutic standpoint. There's nothing being done these days, modern days, in neurosurgery that's had even been contemplated in the years when I began training. Mm-hmm. It's that different. And it's mainly because of technology.
And in the right hands with the right technology, that results in better outcomes for patients.
Absolutely.
Yeah, I wouldn't disagree. Probably technology is the most significant thing.
Certainly in spine surgery.
Yep. Diagnostically, and that was one of the reasons I went into spine, was because when I went in, we'd had CT scans, CAT scans for 2-3 years, and MRIs had just come out. And I realized immediately that MRIs were just going to change everything and that we knew nothing. We knew if I was going to put it on a percentage basis, just for scale for this discussion, I'd say we knew 1% of what we needed to know about the spine. And then the MRI comes out, and that's going to allow us to maybe explore up to 20% of what we need to know. And now we're coming into a phase where even with just the MRI, we're learning to interpret data from the MRIs on a chemical basis. And we can, for instance, with brain tumors, this is true, they can more accurately diagnose cell types of brain tumors with MRIs now than they can under the microscope. Because
and of course, Bob, that extrapolates to fiber tract systems in the brain, how connections from one part to another part are accomplished so that a surgeon knows beforehand, before operating on a brain tumor, exactly where those fiber tract systems are and can navigate to try to avoid them.
Yeah, it's impressive.
Yeah.
Does the entry of artificial intelligence concern you?
Well, it excites me and concerns me. And I guess I would relate my interpretation of AI is that it's a tremendous potential resource to peruse and extract information from an extraordinary amount of data, but you have to ask the right questions. And so it's just like any other situation. You ask the right question, you get an answer, and then you have to follow that up with another question to super select what it is you want to know and kind of purify the information you're getting back. So I think it has an extraordinary amount of potential as long as people don't accept it as infallible.
The concern is for abuse also.
Yeah.
Time will tell.
Well, what I would add would be over-reliance. You know, in the field of radiology, they've kind of done side-by-side board-certified radiologists versus AI reading films, and AI is, you know, pretty comparable in some of these studies. And so with the things that we've talked about, with the ever increasing pressure for profit, you know, you don't want AI replacing physicians, right? I want a radiologist reading my films, right?
I want both.
Yeah.
I want both.
There you go. That's a great point. Yeah. All right. Finish this sentence. The future of medicine depends on blank.
How integrity of a physician is going to be preserved.
Integrity was the first word coming to my mouth also. So we agree.
Well, I cannot thank both of you enough for taking the time to come here and talk about some of these issues. And I hope it hasn't been a miserable experience, so that you'll come back and talk more. And in the meanwhile, we'll keep trying to solve the problems that we can.
Well, great.
Thank you.
Enjoyed being here.
I'm glad. Thank you very much.